Good afternoon, and thank you very much for this kind invitation. I would like to thank the organizers for an amazing conference. I learn a lot every year when I come. So I'm going to reflect on the experience of United Arab Emirates, and for that, I think the UAE. I see the slides, but it's not displayed. If we can display them, yeah, okay. So the United Arab Emirates started deceased donation relatively late. So I'm going to reflect on some concept that helped us, despite the late start, to also have a reasonable annual growth of our deceased donation. So this slide is known to all of you that whatever we see as a total transplantation volume is barely 10% of the global demand. So lots of people are dying, and this calls for prevention as much as we also want to establish solutions. The other point is that due to the distribution of resources, it seems now there is more acceptance that self-sufficiency is not realistic and maybe it's futile. So the resources of transplantation are not the same in different countries. 62% of transplants are performed in high-income countries, with less than 1% in low-income countries. This slide from WHO highlights how many liver, kidney, heart transplants do we have per million per million population. And again, you can see that it's not realistic that countries develop programs on their own. And the harsh reality is that whether you are a low-income country or a middle or high, still somehow more resources are being spent on dialysis, when in fact maybe transplantation requires less resources, but still it has its uniqueness why many are striving to get the right balance. But we also know, being a nephrologist, and you know, that transplantation gives survival advantage, even if people are in their senior years. And furthermore, if you compare people who stay on dialysis to the 5-year survival compared to so many cancers, it has less survival than many cancers compared to transplantation that has more than 90% 5-year. So the question is, what do you do to establish sustainable deceased donation? This was a question that we needed to address. But it's usually multifactorial, and you have to gauge what level of maturity your country is at to start planning. I assume many of you took the plane to come here. So imagine being on the waiting list. If the system is paying more attention to transplant and more resources and not enough to donation, you wouldn't have donation program. And this is where I think it's a common mistake, maybe outside Europe and North America. We tend to resource transplantation, but forget about that donation doesn't happen on its own. It requires professionalization, it requires training, it requires legislation. So this is how we try to simplify this message to our politicians, our economists, so that we get the resources. Because it's, in addition to the scientific difficulty, it has lots of logistics and lots of factors that needs to come together in order to have a sustainable growing model. Maybe this is also one way. Another way that we try to highlight is that in medicine we talk about the golden hour to save myocardial cells or to save the brain, to get thrombolytic at the right time. But we also forget that even for deceased donation, we have to be very fast, because it's that slow decision making that a family may say no to donation, and imagine how many more people would die on the waiting list. So we can also think of a golden hour, golden minute when it comes to addressing donation. And one more thing that we try to address in our country is that to link missed donation opportunity with the quality and patient safety. Every time you miss a donation, reflects back to people who may die on the waiting list. When it comes to the population, we have done a population survey. Even before we had a program in 2016, nearly 70% were supportive. And in this graph, green, it shows that the majority of the population in many countries say yes to donation. And if you add to those people who are not sure, so we can assume that the majority of the public doesn't mind to support organ donation, but it is how we talk to them or how we approach them about it. And also that transplantation, as I think Gabe highlighted, is that it has lots of risks in biovigilance, surveillance. So the system should be safe and should be transparent. And this may be something that we took into consideration. Now, about United Arab Emirates, we are nearly 10 to 11 million population. 88% of the population are expatriates from 200 nationalities. So UAE is quite diverse, high-income country that this mixed culture, we try to, rather than we see it as an obstacle, we said, why don't we see it as maybe a positive factor. So when it comes to results that we will see soon, that nearly 55 nationalities either donated or benefited from donation, because from the get-go we knew that this program, for it to succeed, everybody needed to be equal and everybody needed to have equal chance. So living donation started in the UAE since 1985, but really took a long time for us to get the right legislation in place, 2016. So it was only 2017 that we started the journey for deceased donation. But for us not to lag behind, we started training and preparing the stakeholders a few years before that. And this is our journey. We were not on the deceased donation map whatsoever, but we kept growing to maybe 30 to 40% every year. And I think that 2024, we reached 11.6 donors per million population. And our legislation that was passed in 2016, the leadership got encouraged to pass yet another resolution or law. And in this law, it highlighted that organ donation is a right, and whenever we are not giving that right to those who are relevant to the family members, then we are violating the right. The other key aim of the law signed by the president is that a fair distribution of organ is mandatory, that everybody is equal regardless of gender, ethnicity, race, social or financial status. And it has few other aims of this law, but including that we have to promote cooperation and collaboration with other countries, especially that given the UAE demographic is the fact that we work otherwise with so many other countries. So these are some of the data that you see. If 2024, we had, I think, nearly 350 individuals benefit. I think some of the breakdowns that are not here is that our legislation allows living donation to the fourth degree relatives, but also we have a special committee that reviews altruistic non-related donations. So last year we had 75 related donors, kidney donation, 19 altruistic, 6 paired kidney donation exchanges with collaboration of Mike Rees and his great team. We also have deceased donation, including split livers, as well as some dual organs. When it comes to the model of deceased donation, every country has to decide how to structure it, but we thought it was better to, if we focus only on donation, that the public wasn't going to see it in a good way. And so we aligned services of the OP or organ donation with the command centers, the critical care support units that are overseeing hospital services, referral services, so that we thought the synergy would be that you want to give maximum care, whether it's for donation or for no donation, and this synergy allows us to gain additional momentum. We also know that if you involve critical care staff and if they have a better attitude for donation, that this significantly improves the culture of donation, because it's not only the knowledge, it's a comfort level as well. So when the World Brain Death Project was published in JAMA 2020, We partnered with the primary authors of this publication because, as you can imagine, how could you have somebody that doesn't meet the criteria of death in one state, but doesn't, somebody could be in coma in another state. So we felt, especially in our country, that we have clinicians coming from 50, 60 countries. So you can easily say, well, to my knowledge, where I was trained in Europe, this person is not dead yet. And somebody else will say, so it was really not easy. So we really benefited from this publication. On an annual basis, we used to train and certify through simulation and tool-based kits, 300 to 350 over 3 or 4 years. So really, we started to change the culture of the ICU, and they started to own the process of organ donation in partnership with the rest of the specialties. The other point is that, we made visits to nearly 12 of the 58 US OPOs, and it's not realistic that every country will build an OPO. So we knew that we have to rely on a hospital structure system. And in many jurisdictions, we have 7 emirates or 7 states. We needed to give a responsibility for larger hospitals to oversee the smaller hospitals. And in particular, we worked with health systems that have maybe 15 to 20 hospitals part of the group. So this way, it was easier for us to try to standardize the practices. We also try to be methodical. We involve international experts to come and provide audit reports so that for transparency, we get experts from USA, from Europe to visit hospitals, either transplantation programs or even for donation to come and audit and do workshops and give feedback to the leadership of these hospitals as well as to those who are concerned, including the local health authorities that care about the donation rate in their emirates. So we also divided the results. So this is how you see the donation. We divided in, we are 7 emirates, but we have the large emirates, Abu Dhabi, Dubai, and then the rest of the 5. So you see, while Abu Dhabi started deceased donation earlier, but the latest growth comes from Dubai and the Northern Emirates. So when we give this feedback, we try to stimulate some kind of a healthy competition so that we get more buy-in and more resource allocation. And I think the transplantation resources were more mature in Abu Dhabi, so that's why, although their contribution was not as Dubai, but they utilized most of the organs. So again, we try to maximize the utilization of the resources while we await for a comprehensive health insurance implementation. And these are, when it comes to consent, again, we give feedback to hospitals that some of them are good in identifying, but for some reason, it doesn't translate into consents. And then we develop additional interventions or additional trainings. I think it was alluded earlier about how many organs could be there per individual deceased. And on an average, donors in the UAE tend to be younger in age. And also we share organs that we cannot utilize. In addition to a good, perhaps, ICU care, so we tend to have close to 4 organs utilized per individual deceased, and we try to keep this culture. Now, we, as I told you earlier, since we have people from 200 nationalities, we try to divide the population into the different WHO regions and try to find out about the consent rate, about denials, and then subsequently design some population interventions. So we try to be engaged with cultural events that take place and try to have campaigns including in their own languages, attend their own festivals. So this is perhaps one of the reasons that the consent rate that used to be on average in the 30s, now I think of 2025, it's close to 62 to 65% consent rate on average. But we have some nationalities that the majority would approve, and other nationalities their consent rate tends to be still on the lower side. So this is the EMRO, Eastern Mediterranean. You see that we get lots of referral, but the consent, significantly lower than Asia and then other countries. And then when it comes to outcome reports, these are reported by the hospitals. We are yet to get direct outcomes from an electronic medical records, but the outcomes that are reported by the programs seem to be good, and we rely on international auditors to come and to use it as an educational opportunities as well as engagement. These slides I took from Jeremy Chapman, and we have a single electronic platform that is supposedly we will use for donation as well as for transplantation, in addition to monitor data linkages. Because I think if we want to have a transparent system, we really need to be ready when it comes to the transparency and the audit, and we have to ensure that we are getting all the alignments we need. But it's going to be resource intensive, and that is why we try to align with other national agendas like the digitalization of the healthcare, medical informatics, etc. Maybe in the last section, I will just reflect on the Istanbul Declaration, and this is the photo on my right. It's about the 2007 we met in Dubai, about before the Istanbul Declaration. But I think that it was useful for us to deeply understand the ethical principles so that we don't stumble. We try to build a program that is scalable, that many aspects of the Declaration of Istanbul, if you read our law in its English translation, you will see that is the exact wording of the equity or the ethical principles are captured. And this is important if you are building a program. If you build it on the right principles, it tends to be scalable. The other I would like to highlight is that the World Health Organization in its Geneva 2024 passed a resolution. I think we should all take advantage of this new resolution. But in this section, I would like to just focus on the fact that I think John highlighted in the first talk that even in the US, discard rates are high, etc. So we have to think about how can we achieve regional or different jurisdictional self-sufficiency, because national self-sufficiency is not going to be possible for all countries. And if you read the Istanbul Declaration 2008 or 2018 versions, this is also in line with the ethical principles that country-to-country collaboration should not disadvantage one country. And the WHO, when it comes to this point, it says that official international cooperation for exchange of human cells and tissues and organs should be based on principles of reciprocity and solidarity. And this is what I think this is what's happening in Europe, and this is what we try to apply it in the UAE as well. So right from the first deceased donor organ that we had in the UAE, the first deceased owner, we utilized 2 organs, and 3 organs were shared with Saudi Arabia. So we made it a practice that we never discard a viable organ just because we cannot use it. And this was a very good tactic, because we kept pushing our transplant programs to be aggressive. If they declined these organs, how come Saudi Arabia made it work? So we have a regular organ sharing practices with Kuwait on weekly basis. We send a private jet to retrieve organs from Kuwait, and we transplant for their patients for the services that they don't have. On one occasion, the deceased was from Pakistan. We shared a liver and a kidney with Pakistan, and we were happy that Pakistan is getting into deceased donation. And as a default, Saudi Arabia, whenever we can't use any organ, it gets shared with them. So you have the data between us and Kuwait and Saudi Arabia. So for Kuwait, we retrieve close to 90 livers, but we shared we transplanted more than 100 livers for their patients. And in Saudi Arabia, the lower graph, that we used to share any organ that we don't utilize, but overall this helped them and helped us mature our transplantation program. With that, I end. Thank you very much.